Good morning, esteemed colleagues. Selamat pagi kepada rakan sekerja yang dihormati. I hope I got that right. I really want to thank you, MND Beyond Borders, and really applaud your efforts, in making raising awareness on MND over these past 2 years. It hasn't been easy, I know. And of course, MND Beyond Borders, including HBRSS, Tan Tock Seng, MND Malaysia, as well as Yayasan ALS Indonesia. We thank you from the bottom of our hearts for giving us this privilege of sharing with you our journey. We don't profess to be experts in the field, definitely not in MND, but we just want to share what we have learned so far. We are also on a learning journey, and we hope that we can, and learn from one another. And so today it is it's really our pleasure to be with you. Our special thanks also to Dr. Lim Shu Xian, who has been coordinating this whole presentation, getting us ready for today. And so today I will start off, by first we'll talk about what we're going to do today. And firstly, we will define what MND is. I know all of us here are really experts. I'm among experts, but for those who are new to MND, just a short definition. We'll also be able to describe for you the common symptoms and the physical issues faced by MND patients. And we'll talk about the challenges faced by MND patients. But most importantly, we want to emphasize on the roles of the various members of the interdisciplinary team, especially here in Assisi, in the care of our MND patients. And lastly, we want to talk about the importance of advanced care planning, talking about goals and talking about the extent of care, having these discussions early in MND patients and their families. So my team members today is myself, I'm Dr. Rina Nga, and then we have a home care nurse with us, Ms. Sandra Tan. We have a medical social worker, Ms. Ong Mei Yen, our clinical pastoral care staff, Ms. Joyce Chia, a physiotherapist, Ms. Nyo Hui Sin, a music therapist, Ms. Tammy Lim, and an art therapist, Ms. Vivian Wong. So let me first introduce you to Assisi Hospice Singapore. This is our building. We are located in Thomson Road. For those of you who have been to Singapore, it is just opposite MacRitchie Reservoir. This building was actually built and we moved in 2017, just 5 years ago. And this is our vision, to be the leader and the center of excellence for compassionate and personalized palliative care. Our mission: we are a Catholic charity providing compassionate, personalized, and quality palliative care to adults and children with life-limiting illnesses through our inpatient, our home care, and our daycare services. So a little more about our hospice care services. Okay, firstly, we have an inpatient care service where we look after patients with prognosis of less than 3 months. Then we also have a daycare service where we look after patients with slightly longer prognosis of less than 1 year and who are quite mobile. They're able to come to the center every day. It's like a drop-in center. And we also have transport that brings them to and fro. And we also have a home care service where our home care team, which is nurse-led, goes into the homes and visits patients in their own environment. These patients also have a prognosis of less than 1 year. And so we journey with the patients and their families, and their acuity and of medical and nursing care needs then determines the site of care. A short introduction to motor neuron disease. Well, as most of us know, motor neuron disease is a progressive and a very debilitating disease. It spans over a spectrum of disorders. The most common one that we see is amyotrophic lateral sclerosis, also known as ALS. And it is a very life-limiting illness. It involves the degeneration and the death of motor neurons. Because of this, the characteristics of this disease are progressive weakness and muscle wasting. There are various muscle groups that are affected, and these include the bulbar muscles, which means those around the face and the neck region, the swallowing, the limbs, the truncal muscles, and the respiratory muscles. Interestingly, and of course we capitalize on this, there is sparing of the eye muscles, the sensory functions, cognitive and sexual functions. There are many ways to categorize MND, but for our purposes and intents, we found that this is a very simple and easy way of categorizing our patients. So we use the ALS progression timeline, which divides the disease into 3 main stages. There's the early stage of ALS, where the patients are still mobile, maybe with a bit of fatigue, poor balance, muscle twitching. Then there's the middle stages of ALS, where the patients generally require some mobility aids. They will have more muscle weakness, more difficulty in swallowing. And then there's the late stages of ALS, where there is paralysis in most muscles, very limited mobility and speech, even breathing is difficult. And so they actually depend very much upon, technology and mobility aids. And as you know, because we are a hospice, so generally we receive patients usually in the late stages of ALS. Occasionally, we may get patients in the early and middle stages if they also have concomitant other life-limiting illnesses like cancer or organ failure. So as we can all surmise from what's happening in motor neuron disease, there is a very high symptom burden in the patients. Okay, this includes things like drooling of saliva, dry mouth, aspiration, chest infections, constipation. There is problem with communication as the speech becomes difficult. Okay, there's multiple muscle spasms, and with that there's pain also, and of course a shortness of breath. Then there's problem with feeding and nutrition. Not only these physical aspects, but also the emotions are also affected. The emotions are labile. There's a lot of existential distress. And of course, we can't forget the caregivers. A lot of our patients require 24/7 caregiver with them, and some even have 2 caregivers looking after them. And there's a lot of dependence on technology, and with all this, financial problems are very high. So because of this, we adopt a biopsychosocial spiritual model, also known as BPSS, to deal with this myriad of problems in MND patients. What is this BPSS model? It looks at the totality of a patient's experience in the context of his disease. We don't just look at one portion of the disease, but we look at the patient as a whole. And so we talk about holistic care. We also realize that because of the complexity of all the problems faced by MND patients, there is a need for interdisciplinary management, not just multidisciplinary, but interdisciplinary, where each discipline actually can overlap and cross over to other disciplines to address all dimensions of care. We also recognize that there are distinct dimensions in each person, and no one aspect can be disaggregated from the whole. And with all this, every aspect interacts with the other aspect. And you can see that, even a physical problem can actually affect the other the emotions, can affect a person's spiritual condition. And that's why we know that really there is a need for holistic care. So here in a nutshell is the BPSS model, where you see the biological, the psychological, the spiritual, and the social all interacting with one another in any way that you can imagine. They all affect one another. Let's talk now about our service collaborations. So So Assisi Hospice exists, as we know, as a hospice home care, and we have inpatient and daycare services. And our referrals come then from the hospitals. Most of our referrals at the moment come from Tan Tock Seng Home Vent and Respiratory Support Service, headed by Dr. Chan Yao. But we also receive referrals from neurologists from different hospitals. And they may refer their patients to either to our home care service or even to our inpatient care or to our daycare. And once they are in our service, okay, we still will work very closely with especially HBRSS, because HBRSS will manage the ventilation, the ventilators, and whereas we will actually look more into the symptom control. So these are generally patients who have a higher symptom burden, like a lot of secretions or multiple admissions for chest infections. And that's where we come in and we work closely alongside HBRSS. So because of all this that we have been talking about, okay, that we need a very large interdisciplinary team in order to ensure that our patients have person-centered care. And we try to maintain their dignity and to give them the highest quality of life possible. So we have doctors, nurses, physiotherapists, occupational therapists, therapy assistants, speech therapists, art therapists, music therapists, pharmacists, medical social workers, clinical pastoral care counselors, and our very important volunteers. So now I am going to hand over this session to our home care nurse, Ms. Sandra Tan, who will share from a home care nurse's perspective and will present to you a case. Sandra, please.
Thank you, Dr. Rina. I'm Sandra Tan, the home hospice care nurse in charge of this case. I will just call him Mr. C. Mr. C is a 74-year-old Chinese male. He presented with left lower limb weakness at the end of 2013. At that point in time, he was taking part in a charity walk, and he developed lower limb numbness after walking for 2 km. Subsequently, he was admitted to hospital and was seen in SGH and also in NNI and was diagnosed with MND. And he was still able to walk and drive until the March of 2015, when he was nearly involved in a car accident as he could not brake the car in time. And the symptoms continued to worsen and progress to the upper limbs. In June 2017, patient developed sudden onset of SOB or shortness of breath while sitting. He felt like he was gasping for air. There were no acute symptoms of respiratory infection. Subsequently, he was admitted to private hospital and was prescribed NIV. And he came under the care of home ventilation and respiratory support service in Tan Tock Seng. And subsequently in 2019, he was referred to Assisi Home Hospice Service. Okay, now let me briefly explain to you the role of home hospice service in our collaborative care. It is a nurse-led service, meaning the primary nurse is the case manager who coordinates care to improve the quality of life and work with a team of multidisciplinary members. We may focus on symptom management, symptoms control, and provide supportive holistic care. And for the role of HVRSS, we will usually consult them if there's matters pertaining to ventilatory settings or mask issue. I will elaborate further as we go on in the case. Okay, this is Mr. C at the point of referral. He was ECOG 4 ADL dependent. Due to dysphagia, he was also already on gastrostomy feeding. He communicates by Tobii device. Tobii device is an assistive technology for communication. It tracks the eye movement to spell words from a keyboard and subsequently string them together to enable people who are non-verbal to communicate. He was also on NIV BiPAP at that point in time. And due to SOB, we subsequently titrate and control his symptoms from PEG morphine all the way to fentanyl patch. Now I will briefly cover a few symptoms that we manage in the care of this patient. Common symptoms due to respiratory muscle weakness includes dyspnea and atopnea. They also have sleep disturbances due to episodes of apnea. And due to CO2 retention, as there's ineffective breathing, they normally complain of morning headaches, daytime somnolence, fatigue, as well as confusion. The other symptoms, especially shortness of breath, are basically managed by using opioids to relieve the feeling of air hunger. In Assisi, we use morphine solution as well as fentanyl patch and other, sometimes we will use subcut morphine injections as well. For patients who are anxious, we sometimes use anxiolytics because anxiety may exacerbate shortness of breath. So we occasionally prescribe lorazepam for this patient. For secretion and airway clearance, there are several pharmacologic choices to treat excess salivation or siroria. Atropine drops, 1% eye solution, 1 to 2 drops sublingually every 4 to 6 hours. Glycopyrrolate up to 2 mg QDS, or scopolamine patch, which is changed every patch every 72 hours. For Mr. C, he disliked the taste of atropine and glycopyrrolate, so he opted to just use gauze to in his mouth, changed very frequently by the helper to control secretions. Then there's the issue of pain, as Dr. Rina has earlier mentioned. Primary forms of pain includes neuropathic pain in the extremities, painful cramps in the lower limbs, hands, as well as abdomen, spasticity in the lower limbs, paralysis of limbs and which leads to shoulder pain and articular pain, joint contractures in the hand and ankle joints. For Mr. C, who was prescribed a neuropathic agent, which is pregabalin, so he was on this dosage of 25 mg at 8 a.m., then 12 noon, and 50 mg in the evening. Now I will cover some nursing care aspects for patients with MND. First, I will cover the care of patient on non-invasive ventilation, which is NIV. Caregiver education is very important, and the role of caregiver is very important in the quality care for these patients. Application of masks. So for the mask, we normally rotate 2 types of masks, and we also ensure that the caregiver learn the proper way to put on the mask, meaning there is maximum tightness with minimum pressure. We also ensure that there's frequent change of mask to relieve pressure points. The other important aspect is oral care. Caregivers are taught to do oral hygiene few times a day, or non-alcoholic based mouthwash is recommended, and we provide the patient with humidified air to prevent mucosal dryness. And caregivers are also to observe for fungal lesions in the mouth. Then there's the issue of pressure ulcer prevention on the face because of the mask. Imprints and redness on the facial skin after the mask is removed. So the mask will be on 2 to 4 hours. And after using 2 to 4 hours, the caregiver are advised to take off the mask for at least 10 minutes if the patient can tolerate it. The skin is kept clean and dry. Skin should be well moisturized with products containing arginine. In the case of redness on chafing, a hydrocolloid patch should be used, which due to its thin structure does not interfere with the mask tightness, yet ensuring treatment of the pressure ulcers. These are the 2 types of masks that patients who are on non-invasive ventilation uses. The full facial mask is usually put on at night. The other nursing care aspects that I want to cover is the care of PEG. Okay. A PEG tube is inserted to allow long-term and safe enteral feeding at home, especially in the cases of severe dysphagia. Caregiver education is also important in this aspect. Skin care at the PEG site. Caregivers are instructed to do a regular change of light dressing and to monitor for leakage and also inflammation around the site to ensure that the patency of the tube. Patient and caregivers are advised to pulverize the tablets thoroughly, especially in the administration of medication, using a mortar, and to administer the medication in small portions, each time flushing the tube with adequate water. To ensure consistency of the fluids that is being fed through the tube, normally we recommend using commercially prepared milk formula. This is a picture of the gastrostomy tube, which is inserted through the abdominal wall, and the feeding will be done using a syringe. Back to Mr. C. Since August 2022, Mr. C became increasingly symptomatic with worsening shortness of breath. Worsening shortness of breath here was largely multifactorial. Firstly, he developed pneumonia, which was treated with antibiotics. And there was also issue of mask fit, as there was air leakage. So I contacted a home vent team nurse clinician, and the new mask was fitted, and ventilatory was also adjusted by the home vent team nurse clinician. And due to worsening symptoms, patients started to ask about elective tracheostomy. And at the same time, for our team, we also started to manage these symptoms by increasing the fentanyl patch from 6 mics to 37 mics. And there were several breakthroughs. First line will be multiple morphine breakthrough given to the PEG. And if after 2 doses of morphine PEG, the symptoms does not resolve, subcut morphine injections has to be administered. And patients started using more frequent subcut injections. Our home care consultant started to inquire from Dr. Chan Yao, and our team have a joint visit to discuss elective tracheostomy. So we basically discuss goals of care, burdens of care, and withdrawal of ventilation. Dr. Chan Yao discussed in detail about the pros and cons for elective tracheostomy. The pros would be potential benefit for life prolongation, easier suctioning. The cons would be discomfort in the throat due to presence of a tube, and caregiving needs will increase. There is a possibility patient will be unable to wean off ventilator when locked-in syndrome occurs, because there will be no quality of life from that point. Withdrawal of ventilation may need ethics committee approval and will be complex. Due to patients was not symptomatic at that point, patient did not make any decision for tracheostomy. But subsequently, he did opted for tracheostomy to be done in October of 2022. Now I cover a bit on advanced care planning. It has to be an ongoing communication process. Advanced care planning is an integral part of the holistic care support. It can be summarized as an ongoing communication process that patients receive medical care which is consistent with their values, their goals, and their preferences during serious illness. Challenges encountered by healthcare staff in this aspect is how much information to give and when to give. The amount of information given to the patient depends on the actual health status and the symptoms burden. Because at which juncture you want to suggest to the patient when to do NIV and when to do PEG. It also makes the exchange of medical information meaningful to the patient and their caregivers and their families. There should be ongoing assessment of symptoms to ensure that future care plans are being put in place and decisions are made adequately and for the possible best quality of care. There is also the issue of skill in communicating bad news for the healthcare by most healthcare staff. There is growing evidence that teaching programs do improve physicians' communication strategy and overall satisfaction when handling difficult disease-related topics. In Singapore, we have the Serious Illness Communication Workshop, which is each healthcare staff in Assisi will undergo eventually. This is Mr. C currently at present day. As you can see, he's still ECOG4 ADL dependent on PEG feeding using Tobit device to communicate, but he has a tracheostomy now, and the fentanyl patch has been removed and titrated down over time, and he's only using morphine via PEG to control his symptoms. What was Mr. C's thought process in his decision making? At this point, I can only postulate. Mr. C was actually in the financial sector and working as a remiser. He has perfect mental capacity to decide for himself. And he's also financially able to support all of his decision making, the future caregiving issues that which he and his family will face. And he also have a supportive family and 2 dedicated and competent caregivers in his care. Mr. C may have also wanted life prolongation, although he denies it. Lastly, I want to close with this thought. Decisions about care and end of life are never straightforward. Solutions must be individualized and must involve the wider multidisciplinary team. The aim should be to respond to the patient and to the family in such discussion in an honest, sensitive, empathetic manner, balancing hope with realism. A strong multidisciplinary team is greater than the sum of its parts and can provide robust internal support to its members, using their pool expertise to serve patients and their families more effectively as a result. Thank you. These are my references.
Thank you, Dr. Rina. So I'll just move on quickly to my objectives. So today I wanted to just bring forth towards the social worker lens to identify and discuss the struggles experienced by MND patients as well as their family caregivers. Also, the challenges faced by hospice social workers while we journey with patients and family caregivers. So now I'll just proceed to talk about the patient's perspective, which just now Sandra has kind of shared about Mr. C. So I'll go in further to talk about Mr. C's narratives. So these are some of the things that he has shared with me throughout the visits. He asked questions like, why me? Why am I still here when the life average expectancy of MND patients is 3 to 5 years? That he Googled, that's why he said that. And he also asked his family to bring him to overseas to get euthanasia so that his sufferings can end. So you can see there's a lot of questions, a lot of frustrations as well, which bring us to actually think about what are actually some of the triggers of emotional distress for MND patients, and what are some of the strategies that we can also use to improve the emotional well-being of such patients. This actually comes from an article, and if you are interested, the citation for the article is at the bottom of the slides. So the article actually classified the triggers into 4 components, which I will go through one by one slowly. Firstly is the loss of function and ability, which will result in a reduced sense of autonomy and control, which can actually lead to the sense of feeling of frustration and of grief at not able to do the things that they want to, and they have to rely on people for help. So for Mr. C case, right, because he used to be a very successful man, I would say a reminder, the head of a family, that is very difficult for him to adjust as well. That feeling that he has to rely on someone while he's ill now. So the losing of function can also lead to change in one's self-identity, and all these changes can be very distressing for a person. Secondly is having a threatened future, especially with short prognosis of or even with a timeline in mind. It can actually lead to that feeling of that they are actually being robbed of a future. So the patient will actually start to anticipate symptoms of the disease progression. Some of them will even start to worry, even though the symptoms have not progressed, or even though their illness is relatively stable. So all these worries can gradually lead to feeling of low mood and withdrawal from others. And also the uncertainty of the disease progression can also cause emotional distress because they are not able to plan for the future. There's also this part that they have to actually keep up with constant and multiple changes because of the illness progression. So for some of them, perhaps gradually as time goes by, it's easier for them to fall into a routine. But if let's say the deterioration happened too quickly, it can be difficult for them to cope. And patients or even caregivers may find themselves experiencing burnout and that feeling that they are not in control because of that constant changes. Last but not least, feeling unsupported by professionals or care system. So this is, for example, when they feel that there's actually infrequent care provision, it can cause patients or even caregiver to feel like they are being abandoned to deal with their own illness. And also poor coordination between different professions or even organization, that difficulty in assessing equipments that they require, difficulty in getting financial assistance they require, can also trigger feelings of frustration, injustice, or feeling like they are let down by the system. So what are some ways, some strategies that that MND patients can use to adopt to improve the emotional well-being? It's also categorized into 4, and I'll also go through them one by one quickly. First is finding hope and positivity, and also not giving up. So for many people, perhaps with time, they can slowly, gradually learn to accept MND, but it's also a reminder that although there's actually an acceptance, the attitude of not giving up is actually important for their coping. So for some of them, not giving up simply can mean that I still hope for a cure, or I want to try alternative therapies. For others, not giving up can mean that, oh, I want to find solution to make my life easier, such as I don't let MND define myself, while they continue to lead a normal and valued life. Some of them will start to plan ahead so that they have things to look forward to in the immediate future, so that this actually bring forth some hope to them, that feeling of hope as well. Next is exerting control. So it's actually to focus on the present moment and make the most of what they can currently do. This strategy is actually basically to stop them from worrying about the future or feel sad for what they could no longer do. So focus on the present moment. Different patients may have different definition of exerting control. Some patients may find it helpful that when they exert control over the decision of their care, because it gives them the sense of empowerment. While some patients, to them, exerting control basically means I avoid interactions or information that reminds me of my deterioration or future symptoms. So it really depends on what defines control, what the patients define control. Next is being kinder to oneself by taking a break from MND. So they can do so by giving themselves time and space to adjust to changes. So also allowing them that space to vent if they feel overwhelmed, allowing themselves to lower some of their expectations, and also most importantly is also to learn to ask for help. Experiencing support from others. So supportive communication from healthcare professionals and the reliability of the care will actually help patients and even their caregivers to feel more assured and confident about their care. So this also includes providing information based on their readiness, communicating information in a sensitive yet empathic manner, and focusing on what can be done. Yeah, and also that timely provision of care as well as equipments when is needed. I'll move on to the family caregivers perspective. So Madam B is actually Mr. C's wife. During the visits, I think she also has certain questions, mostly doubts and skepticism about what we can do for Mr. C. So she will ask questions like, oh, what else can you do for him? And she will be a bit upset when we actually talk to Mr. C about his coping and feelings, because at some point, Mr. C was in quite a bad space. He talks about euthanasia, and to Miss Madam B, she feels that, why are you talking to him about this? This brings negativity, and it's just a lot of negative vibe that I just want the whole family to avoid. Yeah. So I'll move on to the challenges faced by the family caregivers. They actually often they will describe their caregiving experiences as relenting because of the progressive nature of the disease. And there's also this sense of helplessness with respect to the recovery. Patients with MND can progress rapidly to high levels of disability over periods of months. So this will also intensify their needs for support, including assistance for their basic activity of daily lives. So caregivers will often need to find themselves having to catch up with the caregiving needs, and this can be also very taxing and distressing as well. Family caregivers may suffer from anxiety, impact quality of life, and reduce social context because of the demands. And they also may experience loss of intimacy as their partner's cognitive or physical ability slowly diminishes. So then why is it important to support the family caregivers? Studies have shown that actually the level of support that caregivers receive can have a significant impact on their psychological, social, and physical state. And because most individuals with MND lives at home, so where their psychosocial functioning is intimately connected to the extent and quality of support that they receive from the family members. So it's also, that's why it's important to actually support the caregivers. Like what we always say, right? Happy wife, happy life. This is like happy caregivers, happy life. Yeah, so if your caregivers is coping well, the quality of care that they can actually provide to the patients will significantly also be correlated. And last but not least, we always believe in early intervention. So because of early identification, so because of early identification, we can also render early intervention to actually prevent caregiver burnout. Next, I just wanted to share some of the resources for MND patients that we have in Singapore. Just a disclaimer that this is definitely non-exhaustive. It's basically really based on my humble knowledge that I have gathered so far. Yeah, so one of it is that I know that the MND patients, they have an informal WhatsApp support group where they will share words of encouragements every day. They will also share information with each other. Sometimes they organize outings as well. So to actually have that sense of community and support for themselves. And then home van team, which is also in part of this presentation also. MMDA, which I think Dr. Chanyao mentioned earlier on. And also there are a few charity organizations in Singapore that assist with the rental of home equipments at low to no rental fee for patients who are of lower income. And these are some of the examples, which include Assisi Hospice as well. For the financial resources, this is definitely non-exhaustive. Based on my humble knowledge, I don't think that in Singapore right now, there's actually a specific financial assistance that caters to MND patients specifically. But if you know of any, do share with us in the chat group. But these are the few financial assistance that that Singaporeans or PR can actually tap on. And usually most of all these financial assistance actually provides claims and payout for patients with high care needs, meaning like they are actually physically dependent, which at some point of time, the MND patients will eventually reach there as well. Yeah, so then we move on to some of my reflection. I To me, I agree. Communication issues are very important for patients with MND and their family, particularly because while deterioration occurs, MND patients will start to experience speech impairment. So healthcare professionals will have to find themselves having to come up with many different modalities of communication. That's why we have our art therapies, music therapies, and also some IT system to communicate with the patient. As what I mentioned earlier on, patients and caregiver can feel burnout by the progressive nature of the disease. But not only patients and caregiver, I think workers can also feel tired and stuck at some point because the patient will actually have a period of oscillation between that denial and acceptance. So you may find that things are not shifting, interventions are not working, and it's basically just stuck there. And this is why this picture is coming from. That's a bird in the cage. Yeah, so it kind of like represent all of us. But there's this reminder for myself is also sometimes there isn't really a need for that intervention per se. Being there as a supportive presence will just be enough. Yeah, just wanted to go back a little bit to Eric to wrap this up. Like what Sandra has mentioned previously, he went for the tracheostomy and his mood is actually significantly elevated because of all the various intervention from the IDT. So as such, he actually developed a very good capacity, emotional capacity to talk about his goals of care and start to open up to a lot of different conversation. Yeah, which is why this picture, then the bird, how the bird is flying out of the cage comes out. Yeah, because of all these wonderful conversations that we can have with him and how all of us feel as well that we are able to progress with him also. Yeah, so it also reminds me that there's this beauty of the collective effort when we work as an interdisciplinary team. Yes, thank you so much.
So on spiritual care for MND patients, okay, here are the 2 learning objectives. To identify the importance of spirituality for patients with MND, to recognize the role of spiritual care for patients with MND and their caregivers. Let us start with the definition of spirituality in our context. Historically, the term was used to describe the practices of those with faith and religions. By the early 1990s, there was extensive growth in research on the significant role of spirituality in patients' care. With this development, the definition has been broadened and extends beyond just religion to be inclusive of other elements that make up a person's sense of self, meaning, and purpose. So let me read out the definition, the international consensus-derived definition. Spirituality is a dynamic and intrinsic aspect of humanity through which persons seek ultimate meaning, purpose, and transcendence, and experience relationship to self, family, others, community, society, nature, and the significant or sacred. Spirituality is expressed through beliefs, values, traditions, and practices. Hence, spirituality is a human characteristic whether one has faith or not, and is expressed through belief and practices in the search for connection with something that promotes meaning, purpose, and personal growth unique to that individual. In the past 2 decades, large and growing body of literature explores the relationships between spirituality and healthcare outcomes of patients living with serious illness. They have demonstrated that spirituality is a fundamental element of wellness associated with several outcomes, including coping with disease, quality of life, improved physical, psychological, and social well-being. So zooming in for MND patients, this paper explores spirituality and/or religious faith as a means for coping. It uses unsolicited narratives from 161 individuals with MND written over 37 years. And these narratives were analyzed thematically. It has the following results and significance. Religious faith sustains and helps people to avoid despair, and personal spirituality helps them make sense of what is happening to them. The place of spirituality and religious faith within ALS MND care should not be underestimated. Next, this longitudinal study performed a cross-sectional analysis to investigate existential well-being and spiritual issues in MND patients and its relation with caregivers' psychological features. 37 patients and caregivers were given existential and spiritual questions. Its findings highlight there being positive correlation between patients' spiritual well-being and caregivers' quality of life and existential well-being. Being on a spiritual or religious path does not prevent one from facing times of darkness. As much as spirituality and faith is often a source of strength and inner resource, when patients are confronted with serious illnesses, others may get stuck, and the search for answers can lead to spiritual distress. In our patient's Mr. C's case, there is existential distress. Why am I still here? Despair and hopelessness, which led to desire to end his life. Loss of purpose. I can't lead a normal life. Meaninglessness. Why me? In providing spiritual care, pastoral counselors serve as guides to invite patients back to their own strength, back to their own selves. It is a recognition that even though the body may be breaking down, the inner being can be restored and even made whole again. I will run through quickly the approach we take as spiritual care providers. Patient is the expert and are invited to take the lead. We try to be as non-invasive as possible with respect to how patients express themselves. Patients are the sole protagonists when it comes to topics, points of views. All the space is taken by patient. There's no agenda on our end. Even if patient chooses to remain in a dark hole, we have to feel comfortable to hold that space for them until they're ready to come out. We allow patients to go explore as many points of view as they wish to. And finally, patients personalize their conclusions into a current personal conviction. Ultimately, patients make meaning and personalizes their conclusion. And the word current here is crucial, as we may find patient in a different place at a different time, and that's okay, because what we provide is compassionate presence that allows patients to be honest with their suffering and explore for themselves how they make meaning of it. As such, and it's cited in this 2021 paper, spiritual care is an individual and relational process. Our role as spiritual care providers is to be able to respond to spiritual cues in our communication with patients and recognize if there are spiritual themes, spiritual resources or strengths, and spiritual distress. And the goal is, with this process of responding to their spiritual cues and spiritual needs, patient can uncover his or her own strengths, enhance them, and help them cope in times of distress. When I first met Mr. C, I was mindful to not bring up the topic of religion, even though record has it that he is Roman Catholic. After all, there were real questions for God. Why me? He had country and Western music blasting in the room when I visited, and he communicated on Toby, "Music is my life." So we began our conversation with his appreciation of music. It was only when he wrote that he liked Christian hymns too, that I was able to approach and see if he was willing to talk about his faith and existential issues. We explored 3 hymns that he said are his favorite, and with his Toby device, he used them to navigate YouTube and read through the lyrics. It was interesting to note and to see him selecting the hymns in a particular order. He began with Amazing Grace, which is a song on brokenness and deliverance from despair. Then he proceeded to What a Friend We Have in Jesus, a song of comfort and promise of companionship. And finally, How Great Thou Art, a majestic song of hope and heaven and God's promises. And it was an awe-inspiring moment as the YouTube visual showed images of lofty skies. Mr. C was wholeheartedly immersed in that moment as he mouthed the lyrics. He typed, "I feel peace" a few times as we followed the words. He also selected a special prayer for us to recite together, the Memorare, which is a prayer for deliverance from despair and affirmation that one will not be unaided. During the session of singing and praying, Mr. C took the lead. The order of the different hymns and prayers, he determined the pace. His wife and helpers joined us, but Mr. C was the one in charge, directing, encouraging us on. At different points, my voice cracked, and I, embarrassed, apologized. And he typed out to encourage me, "You have a lovely voice, go on." He also wanted me to bless his wife and helper. Mr. C may be dependent on others in every physical way, but for that moment, he was in total control, totally in charge. Mr. C also allowed himself to be vulnerable, and we could direct the conversation to hope. He typed, "I have no voice," when we were about to sing, but he had a smile on his face. Important point to note here when providing spiritual care, we engage in what we call contemplative listening, where we do not just listen to what's being said, but also all the senses expressed. So I said to him, "God hears the voice from your heart. The best voice means nothing if it does not come from the heart." So he mouthed the song wholeheartedly. And after that, I felt that he was ready for me to say this to him. "In heaven, you will sing so loudly with all the angels, and you will sing in all eternity." And he typed, "He has much joy and peace." For his wife, Madam B, I had a separate session with her. For her, she did not want to talk about her faith. She only really started to engage when we talked about her grandchildren. And once we created the rapport, she proceeded to show photographs of her daughters. There was great pride when she talked about their achievements. Madam B talks about managing the household while running a business and the difficulties she faced with different helpers coming in and going out and leaving. She closed her business upon Mr. C's diagnosis 8 to 9 years ago. I provided the space for Madam B to reminisce and narrate her stories with only the necessary promptings. Spiritual reminiscence allows someone to tell a life story with emphasis on meaning. It allows one to identify meanings associated with joy, sadness, anger, regret, and other emotions experienced. As Madam B reframed some of these events, she said, "I actually have been quite strong handling everything." It was a cue for me to affirm and acknowledge her strengths. I validated that it took extraordinary strength to go through everything she went through as a caregiver. I asked Madam B what provided her the strength, and she paused for a while before saying, "I take everything as God's will. Maybe God thinks I can handle it." So for her, at least for that session, she came to her understanding that she has it within herself to cope, and she can take pride that she has done a good job. Madam B does not want to wallow in self-pity nor despair. Spiritual care for her at that session was to affirm that she has done well and she can be proud of herself. I will end with these two quotes. Suffering is not a problem that demands a solution, a question that demands an answer. Suffering is a mystery that demands a presence. The next quote is from Holocaust survivor and psychiatrist Viktor Frankl, one who is not unfamiliar with suffering himself. Man is not destroyed by suffering. He is destroyed by suffering without meaning. And that, in that sense, is what spiritual care provider does, providing a compassionate presence for the person to explore how to make meaning of what he or she is going through. Thank you.
into the objectives. And the objectives for this presentation would be to describe the role of physiotherapy in managing physical function and respiratory function, and also to describe the role of music therapy and art therapy, their goals and their commonly used interventions. So the role of PT is to look at impairments, activity limitations, and participation restrictions to see what can be restored, maintained, or what can be compensated for, whether other healthcare professionals need to come in on board to manage this patient, and what is not amenable to our interventions. Looking at physical function, there has always been a question of whether exercise can result in a faster disease progression and whether there can be adverse events due to fatiguing of the muscles. However, there is also evidence that it is safe, well tolerated by patients, and has the potential to prolong function. In the literature, endurance exercise appears to be better than resistance in improving functional ability. However, there is no guideline for optimal exercise dosage and duration for this population. That said, the intensity of resistance or aerobic exercise should not interfere with the patient's ability to carry out their day-to-day activities. In the following slides, I'll be going through the Irish guidelines for physiotherapy in MMD, which classify loosely into early, middle, and late stage as described by Dr. Rina earlier. In the early stage, the goals of therapy were to be maintain mobility and function and prevent falls. And this is done through active or passive stretching, resistive or aerobic exercises as appropriate, the use of assistive devices, and advice on appropriate footwear and falls prevention. In the middle stage, it's quite the same as the early stage, except that we will want to start involving the caregivers more as the patient deteriorates functionally, linking up with the occupational therapist regarding seating or wheelchair prescription, which allows for better positioning in sitting, would be beneficial. In the late stage, where the patient becomes more bedbound, the sleep system would then be really the most important thing. And then we'll look at the respiratory function in the same early, mid, and late stage in the next few slides. In the early stage, the goals of therapy will be to monitor for signs of respiratory insufficiency and to maintain bronchial hygiene. Linking up with the speech language therapist might be appropriate at this point. There are different and just showing different hand positions for manually assisted cough that can help to the patient to expectorate secretions. And the link in the for the YouTube is actually a video, very informative video by Tan Tock Seng Hospital, just putting it there. In the middle phase, there might be a need to link up with the tertiary clinic for the need of non-invasive ventilation. Breath stacking and manual insufflation, exsufflation might be considered to assist in airway clearance and also to help to maintain chest wall mobility and lung compliance. And these are just short videos of breath stacking and manual insufflation, exsufflation, or MIE. Okay, and in the late stage, we continue to do all of the above, but also to continue oral suction. And though this is what the guidelines suggest, suctioning can always be considered at the earlier stage as required to aid in airway clearance. Now let's look at how all these come together for a patient. And we are going to be looking at Stephen, who was admitted to Assisi Hospice in November 2019 to March 2020. He was diagnosed with end-stage ALS, and at this point, he had oropharyngeal dysphagia, receiving nutrition through PEG. He was on nocturnal BiPAP. Functionally, he had no upper limb activity and has glenohumeral subluxation, though he could still stand with maximal assistance. After getting to know Stephen a little bit more, Stephen was actually very goal-driven. He was very keen to maintain his mobility for as long as possible, and he said to me, "I want to exercise, Reason. I want to do the cycling machine that you have in your gym." And the considerations behind this, of course, would it be too much? So we placed him on the active passive cycling machine, and that's it. For exercise purposes, even though he was only on nocturnal BiPAP, we did support him on BiPAP while he was cycling because we were worried that he would fatigue. And this picture just gives a visual representation of what was in the guideline just now. Um, he is on his sitting system, and this is his communication chart that he made himself when he started losing his ability to communicate, as he did not like the use of Toby at that point in time. And we can also see the use of pillows, towels, blankets for positioning of his upper limbs, and the caregiver standing by his bedside, by his side. And before he went home, Stephen was very keen for his helpers to revise suctioning, because that was something that he was always very concerned about, which is management of his secretions, and to be taught how to use the hoist as his function was getting worse. What the guidelines do not quite talk about, however, is the person, which is, the human touch of things. And a huge part of sessions with Stephen was really listening, talking, and understanding Stephen as a person. So what else actually did Stephen want? He wanted to control, and he wanted to be involved, and he wanted to contribute. And well, we were having a small little Chinese New Year celebration music group at that point in time while Stephen was with us, and we invited Stephen to be a part of it. Considerations of how he could participate in the music group was really what functions really do Stephen have left, and what is available, what resources are available to us. And this is him in the music group.
Okay, this is how physiotherapist and I, then when we work together, because at that point I haven't, Stephen is not my case, but he joined my group, and he was kicking on this hi-hat. That's how I get to know him. I would like you to look at this video again, if you can put some observation. Thank you, Sushan. You say you saw his smile. Okay, can you play again? This is a very short video. Just have a and he look at his people around him. Yeah, the responses that he got. Yeah, put those in mind. Yes, his involvement. Yes. I love to look at this video. It's just it's a lot of excitement too. So let me go to the next. It's just a quick check-in of your knowledge. Okay, of this statement, there's a special area of the brain that actively responds to music or art. True or false? A special area of the brain. So put an answer in your heart. Choose true or false. Okay. So the answer is false. It's just a tricky question, because the entire brain is engaged when in a music or art activity. Why it says so? It's because both music and art definitely activate the right side of the brain, where stimulates our creativity, enabling us to express emotion and perceive our life in a deeper and creative way, allowing ourselves to get in touch with the creative and inner self. At the same time, when we make music, there is some decision making, there's some motor, or make art, there's a motor sensory. So actually it activates the whole brain. I believe you are very familiar with the challenges that faced by the individuals with MND now, okay, with all the presenters that mentioned. The physical and the psychological distress that caused by the disease. Explain it in a broader way. What the AT and MT do is to aim to help increase their physical comfort, such as relaxation, or to provide venue for emotional expression, which is important because it's to restore their sense of self instead of being taken over by the diagnosis. The music therapist, one more slide before I haven't finished, I forgot. Yeah, here you go. The music therapist and art therapist at Assisi will work closely together as well. And since you can see here, we address multi-dimensional needs. sometimes we can address the same goals, but we provide a different creative channel. If patient feels more connected to art, then the art therapist provides the venue for their emotional needs, and that when the art therapist comes to play. If patient is more connected to music, that's when the music therapist come to play. So of course, if the patient receive both art and MT, yes, and if that needs are apparent, because at the same time we are also very carefully use our resources so we can reach out more patients. Then that's when the therapists will work together to see how we can make use of our resources. Okay. For here music therapy part, there are many ways to use music, from receptive listening for relaxation to songwriting for self-expression. That then you can see from this list, there's so many different ways of using music. Can meditating or reminiscence to music, free association singing, or even make a legacy project. Just now, Hui Sing mentioned, let's go back to Stephen. We have identified that what Stephen wants, his desires. As a mental health professional, I look into deeper to his needs that make him, what makes him want to control, why he wants to contribute, why he wants to involve. So there's another level of asking all these desires. So actually can also relate to what Joyce mentioned. All these desires can be related to his existential questions too. Who am I? What's the purpose of my life? Am I still Stephen? Who am I to my children, my grandchildren? How would I want my family and friends remember me? Yeah. Okay. So empty goals and intervention for Stephen here. I said 2 goals for Stephen. Is very a huge or abstract goal. The restore sense of self. That is intrapersonal. And then the interpersonal, outside of connect with his people. So these 2 goals. How do we do that? How can we use music to do that? For him to, just now you noticed that way how he played the hi-hat, that he has no speech, but music, making sound, allow him to be heard. Yeah. Receptively listen to music for relaxation, or even talk about the songs. Some music reminded him of his past, just what Joyce mentioned, that when he also played all the hymns, remind him of how his relationship with God. Yeah, their music remind him of when he was a child, as a teen, young adult, as a friend, husband, dad, all his identity. Okay. So in the process of music making, I also noticed music could be a tool for Stephen to connect with the people around him. For example, during our session, the helper also joined in. So I decided to bring him to another level of music experience, which was to prepare a concert, which he didn't even think of it. Okay. So to prepare a concert, so just now you saw Hui Sing that created a sitting system, and he himself also have a communication system. So when it comes to music, I noticed it's a system too, a music system. So I divided here the components of this system. Okay, the first is the equipment part. Yeah, we have the hi-hat that he can step on, and there's these instruments that use sensor to make sound. Okay, then we have. I was inspired by his pointing system with the communication. Then he can probably play this bell tree as well. So let's see the video. Yeah. So this allow him to make these bell tree sounds that allow him to have this problem solving and express his creativity. Okay. The next system is to read the music. Yeah. So if you can give it a try to do this, look at on the right. Okay, you can. I get Dr. Rina to help me here. But before I got Dr. Rina to do the music, okay, here, this is what you can do. Just count with me. Dr. Rina, wait, Okay, 1, 2. Don't wait. Don't wait. Yeah, this is what Stephen would do. He cannot wait. Okay, 1, 2, 3. Or you count with me, right? 1, 2, 3, 4. So the R is right hand, left hand. Okay. So 1, 2, and 3 is right. 2, 3, 4. Correct. Where you go? Right, left, right, left. Right, left, right, left. Okay, then between 2 and 3, there's a right. Okay, between 2 and 3, there's a right. Okay, here go. Right, left, right, right. 你问我爱你有多深，我爱你有几分？我的情不移，我的爱不变，月亮代表我的心。Here you go. That was what Stephen did with his right and left foot. Thank you, Dr. Rina. Yes. So we have this music notation. He learned song with different way of playing the drums. This drum kit. Okay. So this process allowed him to express his self-worth, express his self-determination. That also provide him this sense of achievement. We're gonna have a snippet of his concert, okay? When Uncle Stephen moves his right leg,
随着他动右脚的时候发出的声音。
and now for the left leg.
左脚发出来的声音。事不宜迟，我们掌声鼓励朱先生还有Jenny。
So this is where he has a chance to express himself, that in his own process, that, you know, this is all what he can do. We were talking about low confidence, but he was able to express, this is Stephen. Even all the challenges that I have, I can do all this. And through the concert, he connect with his family and friends, using his concert, choose every song to come with a message as well, that you can see these slideshows that he made while we prepare for concert. Yeah. So this concert allowed him to have a venue for self-expression that allows him to connect with his people. So music therapy research for ALS is very scarce, just because it's very limited of us. And I have listed here, and there are a few studies that we can go to if you're interested in. There are references there. Basically, you can see overview. It's about reduce their perception of physical symptoms, give them the venue for communication, improve their quality of life, and as a venue to connect with others. Okay.
So back to me. And we shall continue Stephen's story with his second admission to us for respite while awaiting replacement of his second helper. And this was from October 2021 to November 2021. Stephen is now tracheostomized and on 24-hour BiPAP. He has also deteriorated functionally and is bed-bound. Once again, putting the guidelines into a pictorial representation, having a sleep system at this time is really, really important, as Stephen is spending all his time on bed now. He is now communicating with his Toby system because he has minimal head movements already. And that's his ventilator in the background. And out of the picture is his MIE or cough assist to help with his secretion management. And you can imagine caregivers at this point play such a huge role as they take on more and more care of the patient. And this is, of course, not just doesn't just take a physical toll on the patient, but also an emotional one as well. And I would say at this point, the caregiver was more expert in the care of the patient than I was. And after relearning the patient's preferences of how he likes his care to be, for example, arm needs to be 25 degrees away from body when he's in rest. My role at this point was really more to give the caregiver some respite for that 1 to 1.5 hours while I was with the patient and having sessions with Stephen. Now I'll pass the time back to Tammy to continue her journey with Stephen.
So when Stephen came back at this stage, he really cannot do much, like what the first admission like. So what can he do with music? Let's see the first video.
Sunshine.
You are my
Sunshine.
my only.
Sunshine.
You make me happy when skies are gray. You never know, dear, how much I love you. Please don't take my
Sunshine away.
So it is a very short moment, but this moment is to have that smile, have that joy. And we took a video and shared with the family. And he took a long time to finish one sentence on Toby. And then it is very distressing for caregivers or for any healthcare workers to just stand there and, okay, guess what's next letter. So during that time, I actually used music for relaxation. And then music also bring him some emotions as he expressed himself through Toby. Here you go.
country road. Take me home to the place I belong. West Virginia, mountain on the
It's a way to use music for emotional release. Even crying is hard for him. But that this country road, that I know during the first admission, he said this song always remind him of, that youth time. And we took the video. He wanted to tweet the video and share with his family. And on the picture on the right is on the daughter Facebook. And then she was saying like kids love this video of Kong Kong. Yeah, that he can continue connect with his family. So you have a sense how actually music. There's no magic, but we really use music for them to joy, and at the same time can get very emotional for the emotional release.
I'm happy for this opportunity today to share with everybody. I hope art therapy is not alien to us here, but if I'll give a quick definition anyway, and hopefully there's a chance to connect and maybe for some collaboration later. Yeah, so art therapy is a distinct discipline, and it is carried out by a trained art therapist integrating creative methods for expression and also for insights into the self as well as healing. So I think just to put the context, the general profile of MND patients that I worked with, they have, invariably full cognitive function, even good eye good visual function, but they would have minimal speech as well as very limited or no hand function at all. So which is why I employ an art on behalf approach, which then also the use of visual images as well as cards and tactile media to work with them. So a little bit more about the art on behalf approach on the next slide. It is when the art therapist acts as the artist. Oh yeah, in a way, yeah. The art therapist is the one that uses the hand, but it is the patient who directs the art. Yeah, so it is a collaborative process with the art therapist executing the ideas that are generated by the patient. So the patient is to exercise full control of how he or she would like the artwork to be. So it is a paradigm shift where patients do not need to be involved in the art making process, but they can be included despite the limited physical capacity. So unlike a lot of people, oh, you know, how can MND patients be involved in art making? But they can, you know, so as you can see from the examples that I will provide, yeah, in the following slides. So this was my work with Adam. Yeah, these are some examples of interventions. So this was an invitation for him to create a collage for self-introduction. So this was a very unhurried process where we flipped through different pages of the magazines and he would select images that he wanted, and I would tear and he would select, and then he would tell me where he would like to position these images, and I would help to organize and paste. And this was the end of or the completed artwork. So yeah, what you see is actually this sense of you know, he said his love for nature and also for brightness, and also things of nature, which brings peace. At the same time, ancient as well as historical architecture. But as we look deeper into the image again, which we do when we process the artwork, what we realized was, you know, the external, what you present to others, the surrounding beauty, and what's inside. And it was very eye-opening when we realized that it was almost like a juxtaposition of what you present to others and what is unseen, which is the artwork versus what was literally the reality of where he was on his bed and looking up to the ceiling. And so there was a moment of that, you know, holding for him as he held that emotion of how he portrayed himself, and yeah, what is the inner insecurities that he had. Yeah. Next. So the next art directive is actually the use of random marks. So this was done using Chinese ink, where then we put a string into Chinese ink and pull the string, and this was what we got. And then what I did was I shifted it around, allowed him to see, and then asked him, what do you see? And this was what he decided it to be, that he saw mountains, he saw a valley, he saw a waterfall, and accompanying within a village community. So I was the one who applied the paint and the colors for him, and so the reflection was, you know, this sense of peace and tranquility that he got. He pictured himself sitting at the bottom of the waterfall, looking up, just taking in the peace that the environment accorded to him. Yeah, so yeah, so this is the unending search for peace and tranquility that I think a lot of our patients desire. And Adam, the patient, then likened this to circumstances of being like having waves of emotion that comes upon him, and this image makes him feel calm and peace as he looked up. And art has a way of allowing the unconscious to surface, as well as the identification with the inner thoughts that gets projected onto the artwork. Yeah, so moving on to the next one. So we also use therapy cards such as these to allow for communication. And so in this session, Nelly, another patient, and David were invited to select from a set of cards before them, like what they want to convey to each other. So these were the cards that were chosen by Nelly. So with each set of 10 that I offered, she picked some, and at the end of it, she only picked 4. I wonder if you can guess what she was trying to convey from these set of 4. I'll leave the suspense there and then allow you to have a chance to try this directive for yourself. Okay, so what you will see next would be a set of 10 cards. Okay, just take a moment to look at them, including my colleagues here. Think of an MND patient that you have worked with recently, or someone who periodically, for some reason, just pops up in your mind. Yeah. Is there a card here that connects with him or her? Okay. Not to worry, if you can't find any here, there's another set of 10 that follows. So I'll just, yeah, leave this here again for about 10 seconds. Is David still with us?
Yeah, sure.
Okay.
I think I can see children playing there on this sunlit field in the bottom right. So that reminds me of one patient I've had who was mostly really struggling with not being able to do that. Sort of that meant everything for her, being with grandchildren and being able to do that, being part of that family activity. And I think that's what comes to mind of the images there. Yeah,
right.
The shared joy.
Yeah, thank you so much. So even that very short story just gave us a lens into the heart and the eyes of this patient, like how family is important. And while there are a sense of loss, but there's also the memory of the good times and what she had and what she continues to hold on to. Thanks for that, David. Yeah, so just moving on quickly. Yeah, so the great reveal for Nelly. So these were the words that she typed and shown to her husband. So acknowledgement of daily struggles, appreciation of support, also the wish and hope for a chance to travel somewhere beautiful again. Yeah, so that was what they used to do and they enjoy. So besides gratitude, also feeling sorry for the stress caused to him, a common predicament for most MND patients because of the care of, or the level of care that they require from the caregivers. Yeah. So as for David, yeah, so while Nelly had an emotional release with the heartfelt words for her husband, David shared his take on his take as well, and he reaffirmed his commitment and support for Nelly. And then, of course, a hug and encouragement followed. So, so these are some of his reflections from the cards. Yeah, moving on. So touch, you mentioned touch, I mean, by a few of our speakers. Some may wonder about the use of digital art because it's so prolific now, whether technology can help MND patients create art. Yes, for sure, there's good potential for that. And there is emerging research on works by art therapists with neuro department of medical health institution, school. But in my own experience, with MND patients, it shows that there's something about the use of the hands, the desire and this longing to reconnect this part of the body, which is one of the earlier losses that they will experience, right? The function. Yeah. So a look at the sensory cortex of the brain may give us a bit of the idea. So the left side figure A shows the normal human figure, right? And then the B shows is odd figure is actually the homunculus, sensory homunculus, which is a kind of map showing what a human would look like if the size of the body was based on the number of neurons in that brain area. So as you can see, then the hands are the largest inside, so which means then this part has the most neurons in the brain area and it has a better sense of touch. So then it gives you an idea of what happens in most of my sessions. Next. So Nelly asked with the birthday of the husband coming up, she asked if she could use the session to create a card, and she wanted specifically a physical card. So she was self-directed in the process and with the choice of materials, texting me what to prepare, what to bring. And then she also decided that she wanted to have an image of a hand. So after the completing the card together, she enlisted my help to pen the message in pen, not typed. in the card, and the words are presented there on the slide. So this was given to the husband, like physical card, and then the husband replied, "Oh, so this is what you were working on the whole time," and of course give her a hug. And so what you see on the right is actually a visual mood chart, a tool which we use to check in and out of with patient to get a quick sense of their mood state. Yeah, not surprisingly, question mark was the first one actually, first in our first session. Why me, right? So time was taken to process that. But in this particular session, it was a light bulb because she was excited with many ideas. And then at the end of the session, she chose the heart. To be able to make a physical card made her happy. And you see, Nelly was someone who was very good with her hands before her illness set in. And making this physical card fulfill her wish to create something tangible for a loved one to hold. So to feel, to hold, and to grip. Our therapists like ourselves may be trained and in different modalities, and sand and symbol work is an intervention that we use. So with Adam, he requested for more sessions with sand, where he particularly wanted to hold and to sort of grip and allow the sand to run through his hands. So in this session with the caregiver, we use fine sand, we use coarse sand, we mix the two, we allow him to swirl his hands in the sand to kind of make movements, as well as allow his hand to hold, to grip, to let the sand fall, and then also to, like what we used to do in childhood, right, bury ourselves in the sand. So while I couldn't bury his body, we could bury his hand and then like so allow him to hold in that position. So he reported enjoying the session, which brought on early memory of early childhood at the beach, and the imagination of the sights, the sounds, and the smells at the beach, and again the calm and serenity. So this sensory process was also a way for him to sort of receive some grounding and emotional regulation. The next one was this led to another sensory modality, which is clay, and he asked for clay to create something with clay, and so there was squeezing, tapping, rolling, cutting, and this feeling good to be able to exercise the hands again. But one thing was interesting. He asked then later to have a clump of clay in his hand, and he wanted to see how much of his hand he could control, his fingers, the digits he could control, and this is what happened. Yeah. So you can see it was important for him to sense and to hold on to what little is remaining. Yeah, so that thumb, I think most of you would see now, it's sort of a little minimal movement there. Yeah. So not just to feel, to hold, to grip, but also to make a mark, inspired from Hollywood Walk of Fame, right? Where we have those permanent monuments to honor the artists and all that. So he showed me a sample of Woody Allen's handprint, and he wanted, like, us, can he do the same? Of course he could, right? So we created this, and now we made it happen. And as with the Hollywood stars, now Adam has his own tangible imprint of his hands and signature. Quickly, I mentioned the use of symbols and sand with MND patients. So in this session, I helped Nelly to create a sentry, which was somewhat like a 3D artwork of her world. The symbols that she's chosen, as you can see, the horse, the warrior, the horse warrior, the princess, the male figure. These are archetypal characters in her world. And then there's also the treasure chest, the pyramids, the Taj Mahal. And these are, if you know her love of travel, these are symbols of travel. A golden cross, a wooden door, a bridge, and these suggested to me items of transitions, as well as the wizard, which possessed the magical powers, right? Her hope for a miracle. So the sentry provided, in the next slide, the sentry shows us that it provided a glimpse into her inner world in the face of transition and navigating into unknown terrain, right? The session supported her emotional regulation, as well as immersing in this creative process where she connected with this theme of life, with its challenges versus death versus hope for a miracle. So that brings me to like the summary of what we have presented from the physio art, music, therapy sessions. MND patients, you see that MND patients actually experience positive mood changes when empowered to optimize what remaining functions they have and to their physical participation, the music, the lyrics, the visual images, the tangible art forms offer them a way to acknowledge their limitations, but also to celebrate their abilities. The themes of this duality, not dichotomy, not one or the other, but they exist together, this sense of control and helplessness, peace and storms, gratitude, regrets, acceptance, frustration, hope and suffering, life and death, all could be experienced at the same time within the same session even. Yeah, so they are able to communicate parts of themselves with these alternative modalities, especially when spoken words are not even accessible to them. So from what we've shared, I hope we've gained a better understanding of how allied health services support people with MND, along with our interdisciplinary team of colleagues. And we hope you've gained some ideas to apply for yourself as well. Now I hand over to Rina to do the task of summarizing for us. Thank you, Rina.